Okay. So I heard that you know a little bit about the varicella disease.
So not much, but my first encounter with varicella was my younger sister. I was in medical school in Costa Rica, and she developed this high fever, and then she developed this little blister. And my dad is like, "Well, you're in medical school. What's wrong with her?" Like, I don't know. So I called my good friend, was a year ahead of me, and a very smart guy. He's now an infectious disease person in Miami. He walked in. He goes, "Your sister's got chicken pox. Why can't you tell that?" I'm like, "I don't never seen it." So that was my first experience. She was a teenager in high school.
Right. So you have a personal experience on this?
Yeah, well, I have 3 stories. My
Oh, okay.
second was the panic with Dr. Odio, because Dr. Odio also worked she worked very close with the hemo-oncology group at the Children's Hospital in Costa Rica, because as we alluded to before, 80% of kids with leukemia back in the early '80s and died, and mostly from complications of infection or bleeding. And she had this big clinic, or they had this big clinic, and she was their consultant. And inadvertently, somebody brought a kid with chicken pox to the clinic. Mm. What I remember the most is her panic. I was too young to understand, I had no experience, but her panic. And I was in Costa Rica from '83 to '89. So there's a later part of that. The Japanese had the Osaka vaccine, but the Americans were just studying it through Merck, and it was not available. The studies were being done to be careful to make sure that it was safe and effective. And they had some of the vaccine through Dr. McCracken because they were studying whether it was safe to use or not. And I remember just picking up the phone and saying, "George, I have this." And him going, "Let me talk to Mark." And then by later that afternoon, all the kids that had been sitting in that clinic had received Visig and the experimental Merck varicella vaccine. Little did I know then, because I didn't have the experience, that that likely saved all of their lives. And the third experience that I had with chickenpox, when I was already in private practice as a pediatrician, one night I developed 103 fever. And then my stomach started itching, but an itching like I've never had before. It was just, I scratch, wouldn't go away. I got up, I was all miserable. I went to the mirror and there was one pox. And I called the internist, Dr. Henry, and said, "Henry, well, I think I have chickenpox." He says, "You cannot have chickenpox. You cannot get through a pediatric residency, all the varicella you saw in Costa Rica. Your sister had varicella, and now be a pediatrician and have chickenpox. Go back to sleep and call me in the morning." By the morning, I had now 3 poxes, right? I had the pox, the one that eroded, and the scabs. I said, "You better come by before you go to work." And he walked in, is, "Oh my goodness, you do have it. Let me call you somebody evacuator." I spent at least 3 days in a Benadryl coma. I was so miserable. Nothing made me happy. It was such a miserable disease to have. Once the itching went away, I was out of work for 3 weeks.
Yeah.
I was in bed for at least 10 days. And then the other 2, all the poxes had not scabbed over yet. So I was infectious, so I couldn't see patients. It was one of the most horrible illnesses I've ever encountered.
Yeah, but there's other complications that you get. We had an intern that had varicella encephalitis. She
Sure.
was really, really
Yeah.
sick. You
Yep.
know,
The interesting thing about varicella encephalitis, the symptoms of encephalitis can precede the pox. And so it can often be a diagnosis that you don't know for 2 to 3 days. And in the pre-vaccine era, the problem was if you had a child hospitalized with encephalitis and they weren't isolated for varicella, you had multiple individuals coming into that patient's room and then possibly the spread. It's interesting. Varicella was regarded when I was growing up and until the vaccine came as a benign and inevitable infection of childhood. There would be 4 million cases every year, 10,000 hospitalizations. 100 deaths. And it wasn't until 1986 or about 1990, and I think you both remember, where we saw what the lay press called flesh-eating bacteria.
Yes.
And there was a statistical increase in the severe skin infections caused by group A streptococcus, which was necrotizing fasciitis that occurred with toxic shock syndrome in many cases, that really led to finally the licensure of the vaccine. In 1992, my group here at Children's Mercy here in Kansas City published on the complications of varicella requiring hospitalization in previously healthy children. You'll be interested to know, while common skin infections were on the list, Benadryl coma was on the list too. There are overdoses of Benadryl in that population. Varicella encephalitis certainly was well described, but it wasn't until we really started seeing those complications that were life-threatening and occurring in outbreak fashion that we finally, on St. Patrick's Day in 1995, had the licensure of our first varicella vaccine.
Right.
And it was Ann Gershon's lab that had done all of the previous research to show that it was not only safe in the otherwise healthy child population, but could be safe in other populations too.
Now, for the medical students that listen to this podcast, what about that Ray syndrome? I've never
Oh, my
seen that. I
goodness.
know about it from the USMLE, and that's about it.
So Rye syndrome definitely was something, and in fact, the association of Rye syndrome with influenza and varicella was highlighted in the late 70s and early 80s. It was when I was a resident at Cincinnati Children's when we started seeing a number of cases, and Bill Balistreri, who's kind of the great grandfather and pioneer of pediatric hepatology, was there with us. And we identified these cases where children presented with intractable vomiting and then coma. And there was very little we could do to support those children. And so there were quite a number of deaths. There was the CDC studies that showed an association between influenza and or varicella plus aspirin exposure.
Yes.
And that's why we do not give aspirin to children any longer, although there's some question now as to whether aspirin was really the culprit or whether or not there could be a genetic predisposition to this Rye syndrome presentation in certain children.
Right. That's a question all the time. On all boards, that question appears.
Yeah.
That was an awful disease. I'm glad I never saw that.
Never saw that.
But we still, I did my residency between 89 and 92. We still feared it. We still feared it. We didn't see it, but we feared it still. So, Dr. Jackson, what was Dr. Odio so scared that would happen to those kids that had cancer have been exposed to varicella?
Well, there's no question that there are certain patients with varicella who had higher risk for morbidity and mortality, but particularly disseminated infection. And so disseminated infection certainly was a risk factor for children with leukemia or other types of cancers. And it was brain, lung, and liver that would become involved and result in severe complications and death. It also occurred more commonly in the teenage population, and that's why there was such a concern about adults becoming infected with varicella and complications that they would have.
Why did they call it the hemorrhagic varicella?
Well, hemorrhagic varicella was certainly something that we saw more commonly. I'm picturing a child that I saw with hemorrhagic varicella when I was a medical student. She was a child with leukemia. She developed varicella. It was very common in the community. It was pre-vaccine, as you might expect. And she hemorrhaged into her varicella lesions and actually then developed Pseudomonas bacteremia and died of Pseudomonas sepsis. And I'll never forget that young girl. She was one of the very first patients in whom I saw autopsy of her complications that she's had related to varicella. And you know the irony of this, Dr. Bravo and Dr. Rogan? The interns and residents of today, they may never see a case of chickenpox. And if they do, they may not recognize it.
They don't.
They
And
don't.
we're not talking about interns. I'm talking about physicians.
Yeah.
In 10 years into practice, they don't know.
Yeah.
They also don't know what to do with it. Because I'm old enough to remember when a parent would call and say, kid has a fever, has a blister in the stomach. And the nurse would tell him, come in the back door and knock on the back door. And then they would bring him in the back to the farthest away room. And they would sit there until I got there. And so the kid said, yep, you got chicken pox. This is what you're going to do. And then leave out the back door. Don't use the elevator.
For those medical students that are out there, why don't you describe, how did you figure it out that he had chickenpox? What did the lesions look like?
I always look for the trifecta.
Yeah.
There had to be a blister. They had to be what I call a volcano, because it looked like a volcano. And then they had to be one that scabbed over.
Yeah, so
in the
different,
same,
different stages of development.
In the same anatomical area.
Mhm.
If I just saw a couple of blisters, well, it could be hand, foot, and mouth disease. I don't remember it ever affecting the hands and the soles of the feet. The only two diseases that will affect that, one, and everybody knows it, hand, foot, and mouth, or hand, hoof, and mouth disease, whatever you want to call it. And the other one that people don't remember is Rocky Mountain spotted fever. When you see an eruption in the palms of the hand in a highly febrile child, that'll be often the first clue for Rocky Mountain fever. And if you don't intervene quickly, you have a real disaster on your hands.
In that tick-borne disease, you're going to see petechial lesions on the palms and soles, and I've seen it with other diseases also. But as far as the lesions of varicella, which you described as a maculopustule and a crust, all in different stages of healing, that is the magical trifecta. I've never heard it called that, Dr. Roberts, but I like that term, trifecta.
It is a trifecta. And if I didn't see it, it was not chickenpox. You have to come back and prove it to me. So thankfully, in 1995, we did get the Merck vaccine. And there is no reason why anybody should not be vaccinated. We should never see that disease again. Before the vaccine, who remembers the chickenpox parties?
Oh, my goodness.
Oh, yeah. Well, because of the chickenpox parties, that's where, because of that, people would be reluctant to take the varicella vaccine before it became mandatory. Why should I get the vaccine? Because, all the kids get better. You have a party, they get sick, they get better. Children do very well despite what we do for them. Does that sound familiar?
Yeah.
Does that sound familiar?
But for those of you that are too young to know what a chickenpox party was, the grandmothers knew that chickenpox in a younger kid was an easier management question than a chickenpox in an adolescent. Less complications, less scarring, less bacterial infections. So whenever they heard that there was a child with chickenpox in their community, they would try to get all the really young kids to play with each other, see if they could all get infected. And I don't know when that stopped, but I think it was into the 80s that was a phenomenon, if I'm not mistaken.
So interestingly enough, there used to be rubella parties too, for obvious reasons. They were trying to infect young girls before they hit the time of pregnancy to present congenital rubella syndrome. And ironically, with COVID, there were individuals during the outset of the COVID pandemic who decided COVID parties would be a good idea. And of course, none of these are good ideas.
No. And so from your perspective, you're a dean at a medical school and you've seen a lot of tragic disease. How have these two interventions changed the world for the public?
Oh my gosh, remarkably. So with the licensure of vaccines for measles and varicella, we have vaccines that are, 95% or greater, producing the immune response we want, 100% protective against disease, and for varicella against severe disease. Very few complications of vaccine adverse events related to vaccines. We still, of course, talk about the small percent, perhaps 7% of children who might develop a little fever and a rash 2 weeks after MMR vaccine. But for the most part, these are highly effective, highly safe vaccines that prevent infection and not only in the healthy child, but importantly, think about in this day and age, we have so many children who we can impact with underlying diseases, not only with cancer, but other diseases for which biologic modifiers or other diseases where we provide drugs that may have adverse events related to the immune function. And we're saving those children too from the exposure. So we've created this cocoon of immunity around not only our healthy children, but also our children who are at higher risk to contract an infection, to become sick from an infection like this, and to die of an infection like this. It really is remarkable. And in fact, for somebody like me, and perhaps for you all, where I saw this being very, very, very impactful just in front of my eyes is once we had an H. flu type B vaccine. And H. flu type B invasive disease, I saw every single day of my residency. And to all of a sudden see that vaccine and licensed, and within a couple of years, it was gone.
Yes. You started out a lot like Dr. Audio, trying to help the child with cancer.
Mm.
Now it's phenomenal, right? 85 to 90% of kids with leukemia survive.
That's correct.
When I was starting, not even half of them survived. And as you alluded before, infection was their biggest cause of death. Do you think these vaccines have helped made that a reality?
There's no question that vaccines against the common childhood infections we've seen have produced this remarkable decrease in the number of infections, but also saved those children. Think about this. Diphtheria, 100% decrease. Measles, 99 point. Mumps, 95.7. Whooping cough, 89.4. Polio, 100%. Rubella, nearly 100%. Tetanus, H. flu type B, nearly 100%. It's just really remarkable if you compare our pre-vaccine era to the era of vaccine, how we've improved morbidity related to infections. It's just mind-blowing.
That's true. So what's next? RSV vaccines for moms and infants?
Yes, you bet. There are a number of different RSV vaccines, not only for moms and infants, but think about this for the senior population. 10% of adults who are over the age of 65 who are admitted with pneumonia to the hospital are infected with RSV. So we have our first vaccine that is coming out against RSV. And for those of us who are pediatrician, to think about this coming first to the adult population
It's an insult.
Might be a bit of a surprise, but it's good that it's coming and it's going to impact those. But also a vaccine that we can finally to give to mothers to prevent this, which will now be a vaccine preventable infection in their infants. That's very remarkable. And an RSV vaccine, think about the vaccines that we have in the maternal population already that will prevent vaccines for their infants. RSV is just going to be added to that list.
I think that may be the end of pediatrics, but
there are plenty of infections that
I think
are still out there that we have yet to tackle.
We just call them viruses.
I've been hoping for 30 years for the day that I can give a child an RSV vaccine and not see bronchiolitis and asthma to follow.
And rotavirus was one of those other entities. There was no question if you grew up in the pre-rotavirus vaccine era that if you grew up after those vaccines were implemented, you never had the pleasure of smelling a rotavirus stool, which was a very distinctive smell. You could walk onto the ward and you knew what that child had, right?
Yes. Yeah. Oh, it's unforgettable. And it wasn't just the child. The sibling was sick and the mother was throwing up in the bathroom. I mean, it was tremendously contagious. It was horrible. Now, I have a pet question of you. I'm very concerned about the survival of my specialty. The amount of student debt that these kids are incurring to become physicians in the in the realm of $200,000 to $400,000.
Mm.
And then, they're just being discouraged from being pediatricians in the academic centers. And financially, our specialty does not reimburse sufficiently for them to service that debt and start a life. What do you, as a dean of a medical school, what do you think the people in Washington who have the power to change policy could do? Because we need primary care.
Well, there's no question that primary care residencies are really important. And at our medical school here at UMKC School of Medicine, over 50% of our students are still pursuing the primary care specialties of family medicine, internal medicine, pediatrics, med peds. If we throw in surgery and OBGYN, that's more than half. There's no question that financing becomes part of it. But also, we have to create a path where our students are passionate about serving within the academic world. So, not only in learning the clinical mission, but the educational mission, the research mission, the advocacy and service mission of our particular primary care specialty. And on top of that, thinking about what we owe to our rural populations. In many of our counties in Missouri, we have about one practitioner, and that's not enough to sustain the health and well-being of our population. So at some point, we're going to have to look at salary equity, not only by specialty, but certainly I would say by other pieces, including gender salary equity within our field. So, you're alluding to a really important point. Within the next 10 years, we're going to have a shortfall of primary care physicians, and that's going to be upwards 50,000 physicians. And one of the reasons is because of medical school debt. So the AAMC is really focused on how we address that shortfall and how we address the debt. And it's everything for medical schools, for lowering costs, for making sure financial aid is available, to improving financial literacy. And actually, in our medical school now, and this is nothing that I had when I went to medical school, we have a financial literacy counselor. She is the bomb in working with our students, understanding where repayment programs come from, and understanding that they can be local, regional, national, and from private organization. What the AAMC says is we don't want debt to stop the dreams of our future physicians.
It
And I
already
think
is.
that's really important.
Thank you very much for your time.
Thank
That's been
you.
a pleasure.
Thank you.
Thank you for
My
everything.
pleasure to be with you both.
Thank you for everything that you've done for the kids and for educating medical students through your career.
Oh, thank you so much. Thank you for letting me be with you today.
No, it's a pleasure.